CFHI, Canadian Foundation for Healthcare Improvement, is a sponsor. We thank them. Johnson & Johnson, regular sponsor. We appreciate that. Roche and National Research. I know there's National Research people here, and we really appreciate their support, and maybe you'd like to agree with me that we appreciate their support. You know, and I should mention Sinai. This auditorium is always made. Joe Mapp is a great fan of us and always makes it available. So really, Sinai is a great supporter, and we should put them on the sponsor list next time, Rebecca. So I will spend no detail on introducing Shelly Jamieson and Terrence Sullivan.
So I'm delighted to be here talking with Shelly Jamieson about CPAC. I have a very small role in CPAC, so I'm declaring this and a commitment. One of the interesting things about this organization is that it was developed really through a mix of professional activism and straight public advocacy. So it was created by a coalition of organizations, many of whom are present in this room. Some of whom are present in this room almost 10 years ago now, and with the help of a very, very active patient community and other stakeholders, there were front page stories and other stories in the newspapers across the country about the burning requirement to create a national organization to help align efforts in cancer and to help create a more focused scrutiny of what was going on in cancer within our quaint and interesting federation, which is Canada. So we are now essentially, is it 9 years?
Yes.
9 years in from the creation of this innovation in disease state coordination and management in Canada. The partnership is a very unique structure, and here we are in year 9, so towards the end of the second mandate for this organization. So maybe I could just go straight to you, Shelly. You know, we're in year 9 of the second mandate, looking forward optimistically to a third mandate, but maybe you could say a few thoughts about what you think the sort of important achievements have been in the first and second mandate, and we'll go from there.
Sure, thank you very much, and thank all of you for joining us this morning. This is great. I've only been on this CPAC journey for 3 years, and I was attracted to it because of what Terry just pointed out. It's really a public policy experiment. There isn't anything quite like it in the country. Disease-specific pan-Canadian work. And this fantastic country is a federation where the provinces, by and large, and territories have responsibility for their own health care. We are 100% funded by the federal government. And so how did that happen, and how does it work that we are able to work with the provinces to have impact and influence? And I guess what I'd say I'm most proud of is that in the first 5-year mandate, we were able to prove that we could continue to work together. And those who went before me, Jessica Hill was the first CEO, and I see Lee Fairclough here today. There's people who were on the ground day 1 when there were 2 or 3 people, and they had to figure out how to build this thing. If they were doing that without already having the support of those 700 advocates and experts in cancer control, I don't know if it would have been successful. So we didn't have to talk each other into working together, but we had to learn how to do it. So the first mandate, we did a lot of convening. We got a lot of people in rooms to talk about specific issues who hadn't been in rooms together before. And we had to establish what was CPAC's role in that room. Were we there to direct something, or were we there to set the stage for true collaboration? And I think that our stakeholders today would say they still have skin in the game. You know, they wrote the original National Cancer Control Strategy prior to 2007. It took like a decade. It wasn't, you know this, you were part of it. So they wrote the strategy. They said we will stand together and do a better job of collaborating if this initiative is funded. And then they proved it by standing together, and they're still standing together today. So first mandate, we had to do some things together that looked like they were improving the system. And that was fundamentally important. And I think a couple of key things for me, the system performance report, we were and are stewards of the National Cancer Strategy. And we had to begin to measure and report on where we were, even if it was baseline measures. And so I think the first system performance report was in 2010, but it was a lot of work to get all the jurisdictions together to agree on what are we going to collect together, how are we going to report on that. And like anything in healthcare, when that first report came out, some nervousness about who does really well and who does poorly by indicator. But we've really come such a long way. There's been a profound change in that. And I believe it's because the provinces see themselves at the table, bringing their data, part of the decisions about what's going to be collected, what's going to be reported. It's not a gotcha kind of moment. It's more, we unveil these reports, and we hope and believe that policymakers around the province are looking at how their jurisdiction is doing and asking questions about why is this jurisdiction better? Is there something we can learn from that? So I think system performance was a really important one. I also think that our Canadian Partnership for Tomorrow project, which is certainly an ambitious project, and it started, and if it hadn't started in the first mandate, we wouldn't be about to launch it next month. So 300,000 Canadians have signed up. That's 1 in 50 between the ages of 35 and 69. They gave blood, half of them. They have filled out detailed questionnaires about their lifestyle, and they've agreed to be tracked through their adult life with their health data, so that one day, researchers who will access this data will solve some of the most pressing problems in cancer. Now, that project started in the first mandate, and it's been a tough, long slog, but we're there. And I think if we hadn't laid that groundwork in the first mandate, I'm not sure we would have started it in the second, to be honest. In the prevention world, it's tough to get money for prevention projects, in cancer, but in anything, primarily because it's outside of the political mandate cycle. You don't tend to see benefits within the mandate of a political cycle. But we've been able to carve off a fair bit of our budget to prevention initiatives. And our CLASP initiatives, which were linking science and action, were sprinkled across the country. And they were a fantastic way to get the country starting to work together and started to build our model about bringing people together on a regular basis to talk about what they're doing and share their plans, evaluate the process after and share the best practices. I mean, this is the well-worn path. So those are a couple of examples of things that certainly started in the first mandate, and there are others, but I'm sure you'll ask me about them.
Can you say something about the second mandate? So here we are, closing in on the...
Yeah. I'm extraordinarily proud of the work we've done in the second mandate with our First Nations, Inuit, and Métis population. And I'm proud of how we've done it. So the First Nations, Inuit, and Métis partners have written a cancer control action plan. Let's just pause and think about that. They have a plan that they wrote and we facilitated the creation of. And now we are busy picking off things in that plan to do together. And we're focused right now on how First Nations, Inuit, and Métis people receive their diagnosis and how they're discharged from their oncology experience back into their community. And we've got $11.2 million being spent in 8 jurisdictions across the country, 8 provinces and territories, excuse me, to look at projects specifically targeted at those initiatives. And again, we're using our same process throughout those projects, which are multi-year. All the parties are getting together and sharing how's it going, what are the obstacles. They're learning from that. They're all agreeing to evaluation, and best practices will be shared. The other thing that I'm very proud of with the First Nations, Inuit, and Métis folks is we have a special governance for that work. We have a National Aboriginal Organization caucus, so leaders and of those three peoples who, you know, we don't do anything on that file without them. We talk about it all there. They have the same kind of ownership that our other stakeholders, I hope, see in directing our other work. So I think that's been a fantastic piece. We, like the rest of you, are looking at patient-centered care in a more serious way and starting some work on survivorship. There are 1 million Canadians today who are survivors of cancer, and we don't tend to target and look at things that would help them as much as we could. So that's another piece. The National Staging Initiative, top 4 cancers, 90% of Canadians, you know, their stage data is captured. That's a fantastic thing we were able to do together. And I guess on the screening front, I would say that you know, and we always have to try and figure out what did CPAC do. And the folks I work with tell me to stop saying this, but I always say we don't do anything, and that's not quite true. But it's driven by the collaborative effort. So what we hope we do is step into a space and accelerate progress that might already be on somebody's mind or on somebody's plate. But just because it's on the plate in Ontario doesn't mean in Prince Edward Island they're able to address things. So screening is a great example. It took 50 years to get a cervical screening program in this country in 8 or 9 jurisdictions. It took 10 years to get a breast cancer screening one, colorectal screening, 3 years. Now, in part, it's because all our partners realized that screening was an important investment, and I understand that. But the degree to which the whole country's been able to move, and in fact, we have 10 jurisdictions and 2 territories with screening programs in the short space of 3 years. I think it's because people agreed that working together was valuable, and because we have dollars to spend. And I would like to take this moment to say, we don't have any sticks. Nobody has to work with us. In fact, they often choose on particular projects to opt out, and that's fine. Maybe we're not a priority then, or they're not keen on the initiative. But we do have carrots, because we have a budget of $50 million a year, and we are able to seed these initiatives, to accelerate things, to speed up processes by providing resources that people would otherwise have to fight for against other initiatives and their overall health budgets.
Fantastic. So let's go straight to the heart of the issue of the federal-provincial stuff. You've talked very nicely and clearly about some of the priorities in the first and second mandate. Some of them align very well with the federal power, so to speak.
Yes.
So research, information gathering and collection, First Nations, supporting First Nations organizations, reporting, beginning to collect and report on performance. But what are the challenges as a C organization, a pan-Canadian organization, in trying to do something in support of the provinces and playing really a kind of a bit of a brokering role in capacity between smaller provinces, between the PEI and the Ontario, which has, you know, a very well-developed infrastructure and is frankly much better led than it used to be in the last couple of years. So it's how does the organization actually map itself onto this strange configuration of capacities within the country? And I'm going to come back to this.
So I think there are several things. One is, you know, we aren't all the same. All the provinces are different and proud of the difference. So you have to respect the difference. People say to me all the time, well, the health system is organized differently across the country. How do you know who to work with? And I'm not fussed. We're not trying to impose a structure on anybody. Somebody's in charge of cancer control in every jurisdiction. We have to find out who that person is, and they sometimes have a title of CEO, and other times they're a VP of everything, a whole bunch of things, in a Ministry of Health structure. So very different. But they all have the same problem. Cancer actually presents itself very similarly across the country. So we find out who it is. I think the other secret sauce, if you will, is that we're not viewed as the federal government. So I go in to see ministers of health across the country and deputies across the country and speak to them and our First Peoples as well. So sometimes when things aren't well between the federal government and our other partners, we wonder if it's going to impact our work, and it does not. And I think in part it's because we're an arm's length agency of government. In part it's because we do have funds. But it's also because over time, the fantastic folks who have worked on the stewardship piece have been able to establish that they listen. And I believe that we are a trusted partner. And so we are able to leave those things to the side. I guess the other thing I'd say, I used to work in the Ontario government, and I watched agency management, if you will, for 634 agencies at the time. I happen to remember the number. And they were all different, and the relationships were in various stages of disarray, right through to really excellent relationships. I have to say, running a federal organization is a delight. And the accountabilities are very clear.
Right.
There are no surprises. I'm in touch all the time with a contact inside of Health Canada. I never surprise them. I hated surprises. You might remember I hated surprises.
I do remember.
And so I don't surprise them, but they don't interfere. They don't muck around and meddle. They know that we're an evidence-based organization, and they know that if we don't have relationships with these various stakeholders, it's not going to work. So and then there's some key accountabilities. Our business plan goes in January 31st, and the civil service has 60 days to review and approve it, or our funding stops. And our funding would stop. Well, I understand that deadline, and the federal civil servants I deal with understand theirs. So I have a logic model that had to go through Treasury Board. I have this business plan every year. There's some rigor to the business process that I like the clarity. So I think that's a wonderful little piece.
Can you say something about the predictable and unique challenges with Quebec?
Yeah.
It's like we have 3 Canadas.
Yeah.
We have 3 big provinces, 4 with Quebec,
Yes.
and a bunch of smaller provinces. And then we have...
Yeah, and then we have the territories.
Yes.
Which is, so I would say that Quebec is a valued partner in our work. They have an observer seat on our board, and I would like to mention our board is made up of representatives of that group of 700 people who first were involved. So the CEO of the Canadian Cancer Society sits on our board. There's a couple of deputy ministers of health on our board provincially. There's a federal rep. There are oncologists, researchers, scientists, survivors, advocates. It's a big board. And there's regional representation. And what that means is everybody's in it together. But there are moments where you can imagine a researcher says, let's take 3 years to look at this, and a patient says, no way. So there are those moments where we have that. Quebec sits at that table as an observer. That just means they don't vote. We work very hard with Quebec to understand what are they working on, what are their priorities, and frankly we do that everywhere. What are their priorities and where might we have a role? And Quebec opts in and out of various initiatives based on their priorities and their interests. So we value their participation. We also have another member on the board, Dr. Andre Robideau, who is from Quebec. So not representing the government, he's there as an individual, as a practice leader, exactly. So we hear the voice in Quebec, and we're looking for the sweet spot where we can assist them to reduce the burden of cancer for people who live in Quebec.
Kelly, just to step back to comments you were making earlier about the system performance, and a little bit about how far can we actually go. So, the system performance work has been fantastic in sort of laying out a picture of what's going on in Canada and going through the usual cycle of making data better and purification through utilization. And I think the provinces and the cancer authorities in the provinces have used that data. One of the challenges is how deep can we actually go? So we're just finishing up, as you know, a picture of surgical outcomes across the country for all provinces except Quebec. It has some challenging information in it. And there are other areas where we could be looking at pushing a little harder with the provinces. How far can we go at kind of trying to look at essentially variation in care and try to create better processes across the country to raise the bar uniformly as much as we can.
Right. So it's a great question, and Dr. Heather Bryant, who is the soul of the cancer control mission in our organization, is actually looking at system performance and trying to say what's next. So it's been on an evolution. So what will it look like 2 years from now, 4 years from now, and how do we have more impact and influence with whatever it is we're doing together? But I want to address with you one of the things I think we learned in the first mandate is it's not worth working with people who aren't willing to work with you. So we're looking for partners who are willing, because otherwise everybody else sucks all the energy out of you and you don't get anything done. So I think it's important that whatever is decided about system performance and what we do next and where we make an impact is decided by the people the very jurisdictions who give us that data. I mean, one of the things I love about when system performance reports come out is that nobody says, I don't agree with the data, because they gave us the data. They've worked with us all the way through. We even helped them with their communications plan the day of to understand when the media asks you about this indicator, here's what it means, here's the interpretation, if you'd like to use this. I think there probably is a limit, and I also think our board has asked us very clearly, when will CPAC be done? I mean, our job was to get people working together. There's probably an end point to that. I don't think it's next year, frankly. But there will be a time when an organization like ours won't be needed to catalyze this behavior. I mean, maybe I'm an optimist, but I think as there's more transparency around evidence and there's more reporting on effectiveness, that if we were just monitoring the national cancer strategy and the indicators are all set up, well, someone perhaps could do that other than us. But right now, there's more work to do.
So maybe one more question, then we'll just open the floor for further discussion. The question that sits in the minds of many who work in provincial delivery organizations is, how do we work together with CPAC, and in what way can CPAC have an impact on the population and on patient-level care on the ground? So it's back to this servant leader role, and what is a reasonable ambition there?
Yeah. So, I would say our ambition is that together we're better than if you were on your own. And a lot of that has to do with attribution. So we see things happening in provinces and we know we've had a hand in them and nobody's mentioning that CPAC either funded something or whatever. But that's fine. Let the provincial cancer agencies take the credit for doing something great. That's fantastic. If we're not helping influence what happens through the provincial cancer agencies, then what's the value of what we're doing? We don't deliver cancer services, they do. So I think we have to be aware of that impact. And I would like to say, especially since we're in Ontario, Ontario plays a special role in that, and that role is in the Federation writ large. At one point, I'm 108 years old, I'm just really well preserved. And at one point in my career, I was the Deputy Minister of Transportation for Ontario. And I used to go to federal, provincial, territorial meetings, and I was amazed at the resources I had compared to everybody else at the table. I was better prepared. I had a world-class asphalt expert. You might not realize how important that is, but it is. We had the best laws. We had the best road design. We had bridge replacement technology that was leading in North America. We had the best safety record, goes on and on. Also had a critical mass. Like, I had a big organization and people were envious of that. That is the federation that is this country. And that is the role that Ontario plays in that federation. It doesn't matter if you're talking about roads or you're talking about cancer control. So much is expected of us, and that sometimes is irritating. Frankly, we're going to do all the work and give it to everybody else. And the answer is yes. That comes from being a central force in the country. It comes from some years of prosperity. We might not be feeling them now, but some years of prosperity where we had things that others didn't. And when you speak to the Atlantic provinces, you realize they hardly have anything to deal with any complex issue, but certainly to deal with cancer. So the one thing I say all the time when I go across the country is, if I pick Ontario is very busy running its own cancer control system. Like, how much time should it spend thinking about the rest of the country. So this is where an organization like us, I think, can be helpful. Because if, and Ontario is willing to share, and they share often and generously, we can help make it easier by spending the resources, convening the groups, and helping share the knowledge. And I think that's an important piece. And if you go elsewhere in the country and see how many problems people are coping with and how overwhelmed they are, it makes sense. We're an enormous country and not many people. You know, it makes much more sense for us to share what we're doing on behalf of all Canadians so we can reduce the burden of cancer for them.
Thank you. So let's open it up to the floor here. If people want to jump in with questions or comments.
So thank you for this terrific discussion. Shelley, I want to circle back with you on your comment about prevention and your comment, who could disagree, that it's hard to get money for prevention because of the understandable short-term horizon of government. Prevention, well, let's just say provincial government. So given your experience in the provincial government and thinking about prevention as interventions of the individual behavioral level, which I think with the class and a lot of the work that a lot of us do is on that level, but thinking about the policy end of things and regulation, legislation, taxation, I mean the levers that provincial government has. Here's my question. To what extent do you think CPAC could have a role in helping us, Ontario for one example, make the case to provincial government on the policy matters, not the individual change behavior, I have to walk more, and exercise more, but making it easier to make the healthy choice so that, case in point, the broadening of access to alcohol in our province. We provide an evidence-based set of recommendations, evidence synthesis and recommendations related to that. But if we had here's a guess, if we had a health technology assessment or a piece of economic analysis that showed us what the real broad health impacts, more policing was required, more emergency department visits, and all the tablets run up, I don't know whether it would have been more, it helped us be more persuasive. So to what extent can CPAC help us with these larger policy matters at the provincial level?
Yeah, that's a great question, Linda. And I actually think if we get the opportunity to move into a third mandate, we will be expanding our health economics piece that we're doing. We do some work. We have a risk management model that involves costing at that kind of level. And, Heather Bryant and I were in Melbourne, as were you, at the Union of International Cancer Control, UICC conference, World Cancer Congress, I guess is the best way to describe it. And I was really disappointed and dismayed at how poorly the cancer control world articulated its economic case. And we have to do a better job because actually, I'm just guessing, I won't pick this government, but they made the choice for political reasons and for economic reasons based on the economics right in front of them, not the total costing. And that's not unusual, let's just say. So we have to do a better job of showing evidence of cost effectiveness. And that is the number one issue pointed out to us by the Canadian Association of Provincial Cancer Agencies, which is the CEOs of all the cancer agencies across the country. And I get to sit on that organization and listen to them. And what I hear, number one issue, sustainability. Well, that is an economic driver. So how are we going to choose wisely? How are we going to make sure that the drugs that are listed and selected actually matter and make a difference? And how are we going to make that case? Because if we sit around waiting for somebody else to make the case, I don't think it's going to be made. I will say we do have a regulatory directory. So for things like suntan beds, tanning beds, we've tried to put language, and we're trying to speak more directly to municipalities who are making these little regulations and say, look, here's the language, here's what exists across the country, and so people can. So we're moving increasingly to influence the policy side of things, even at the municipal level, and I think we're going to have to do more of that. But I used to, when I was in government, I was very frustrated by the times that civil service would come forward, and so I'll speak for myself as well, and say, you have to do this, it's in the public good. And if you don't do this, people will die. And I'd say, well, first of all, if people will die is the measure, there's a long line of policy initiatives where if we don't do something, people will die. So sadly, that's not as compelling as you might think. And then people would say, we can't really do the cost estimate for the future impact, because how do we really know? Well, actually you can. There is some modeling, you can do some, you have to do some homework, but you have to make the case that you're changing the face of the economy and the quality of life for somebody going forward. And I didn't find any other country at the UICC who was doing a great job, where I thought we could say, oh great, let's go see what they're doing and copy it. So I think if we get a third mandate, we're going to have to focus on sustainability of drugs. A lot of people in the drug space, I always say at CPAC, we're looking for the sweet spot. I want to go where no one else is, because everybody's doing important work and I want to take it over. But one area that is interesting to me is the post-market surveillance piece of drugs. So we know what drugs we're supposed to be approved to do, but we don't actually circle back and say, well, who actually got them and what happened for some of the really high-cost drugs. And I think that's a piece of work that we're interested in perhaps funding and looking at, and in concert with all of our partners who are also doing important work. CCO is hosting a conference coming up next month that will look at some of these very important issues, and we're hoping to learn from it.
If I can just follow on before we go to the next, Shelly, on this point of, CPAC cannot provoke provincial governments, but there are ways, and maybe there are ways we haven't explored to put evidence on the table that others can use to provoke provincial governments. And I'm saying this not to be provocative to provincial governments, because that's the way policy gets made. That's how CPAC was created. So on the example of drinking, on the example of reducing variations in care, do you think there are ways in which we can cause things to be done, even if CPAC doesn't do it themselves, to kind of create crowbars, so to speak, to move on the policy front? Because that's the big challenge for CPAC, is really not to intrude in the jurisdiction, but to give the jurisdiction tools that might be helpful.
Right.
But,
Yeah, that's a great question. And we are precluded in our funding agreement from being an advocacy group and from lobbying. So we cannot do that, which is actually great. It's fantastic. But Terry's quite right. We can create products that other people use. And especially if they're respected and they're full of evidence, that works really well. I met with a minister of health, west of here, I'll say. And she said to me, Shelley, I can't go out and say to people, the evidence says you don't need a pap smear every year or even every other year if you're in this age group. You need one every 3 years. I can't do it. I believe you. I'm sure it's true. But I can't. It's political suicide for me to go out and do that. She said, but if you write a report that says, here's the evidence, here's what happens when we overscreen, and here's, and other jurisdictions actually are accepting it as well. I'll run out with it and say, look, here's what the experts say, and I'll do that. But I'm not going to come forward, I need something, I need this tool. And so I think that's an important role for us. I also think in lung cancer screening, we just had the low-dose CT scan issue, where I think we showed that as a group we were very effective at getting ahead of something that was coming out. So an emerging issue where we knew that if we didn't work together as a community to figure out what happened when the young minister staff person ran down the hall and said, oh my goodness, what are we doing for lung cancer screening? Before we know it, something could be set up that might not work in our provinces, number one. And number two, there might be a whole peripheral cottage industry that gets set up if we aren't careful, and some screening that's not necessary. So what did we do? Well, in this country, when you call the experts together on any one specific issue, it's like 12 people. It's not 2,000, it's 12. So I'm picking 12, but I don't know what the size of this group was. They worked for a year looking at that evidence. looking at the Canadian context, trying to understand what it meant, and preparing people, not with a pat answer, but there was a framework that got put up, something that you could hang your hat on when you went to see your minister, to say, look, we have an expert embedded in this work, they've been talking about it for a year, here's what the science means, and here's what we should do from a policy perspective. I mean, I think that's an example of something that we did well together, and we were the stewards of that. We helped create the forum for it, but it was about listening to the people who already are experts in that area.
Shelly, in terms of the information to the public, it's helpful to hear that you cannot advocate directly with federal or provincial government, but there's a tremendous amount of public confusion about all this evidence, or so-called evidence, or not evidence at all. And the cancer world, as people are entering into it in the boomer era, it's getting more and more complex from the public's point of view or family members. Can you describe your vision of CPAC's role in helping make sense of all of this?
That's just a fantastic question, and we were quite split in our organization for a number of years about what should our relationship be with the public. And I work right at University in Front Street, and I often look at my office window and say, like, I don't care if that person knows who CPAC is. And I don't. I actually don't think our space is to be recognized by the public. I do expect that the public, or I hope in this province, that they know two organizations, the Canadian Cancer Society, because I think they're a rock and an anchor in the cancer world, and Cancer Care Ontario. I mean, that's the voice to the people about information, and I don't expect that they would know about us. In the cancer control community, I hope that people know who CPAC is and what we do in bringing that community together. And I'll be honest, we're not there yet. I would say the leaders in cancer control in the country know who we are and what we do, but you don't have to get too far away. I do bump into people in cancer control and ask them what they know about CPAC, and they don't. So I think we have, we need to have that level of awareness. But that's back to the attribution thing. I want Cancer Care Ontario and the other agencies across the country and the Canadian Cancer Society to be seen as the voice. We have a portal at cancerview.ca. You're welcome to look at it. We know that some public, and largely I'd say the educated public who get on Google and try to figure out what's going on, we know that the public does go to the site, but we aren't creating the site for the public. We're creating the site with resources to support the cancer control community across the country as a place where people can go and get information. And you're quite right. I say about 50% of cancer is the Wild West. Like, there isn't evidence. In a grown-up world, 5 years from now, I would love it if health reporters who are questioning, the cure of the day, and cancer, there's a lot of that stuff. I would love it if they were checking with us to say, what's your opinion on where the evidence is on this particular treatment or this particular cancer, or are these the right numbers? Because I would say there are people in the cancer control community whose messages aren't actually based on evidence either. So it would be great if we were all having a conversation that we knew was based on real numbers, etc., and that we were seen as a place where you could go to check that out. And we're not quite there yet, but we're getting there.
Any initiatives for the third mandate that maybe you're toying with that you'd like to float?
Sure. We're deep in a strategic planning process, and because I've described our model, you'll understand it's not about us sitting at CPAC and writing the strat plan. This is created by that same community and needs to have buy-in from that community to be true to how we approach our work. So I would say a couple of things. The First Nations, Inuit, and Métis work, there's a whole report full of things we could do. And we're actually getting some traction doing the first things we did. So let's keep using that path and move forward and try and improve the lives of people who don't have a lot working well for them right now in terms of the community supports that they need. So that's one. Palliative care, end of life, survivorship, and I'm not adding physician-assisted suicide right now because I'm not sure where that work will be housed or stand. But the first three, we think there's some leadership that we can bring to the table. In fact, we've recently formed a network for palliative care and end of life across the country, and we've got some initiatives underway. But that, I would say, is early work. One thing we found with the palliative care community is it's been running on a nickel and a dime and on the big hearts of people for a long time. It's not as organized as you might think it should be. So that sounds like a sweet spot for us. It sounds to me like we could step in and not duplicate anything anybody else is doing, but maybe something about a national palliative care strategy would be a good idea. So that's one. And then the last example I'll give is we are blessed in this country. There's a ton of data sitting in our cancer registries, a lot of information, and it's increasingly our view that it's underutilized, and that Canadians actually think that they've been part of something that is really going to change the face of cancer. And there seems to be a bit of a disconnect. We're wondering if we could play a role in, again, facilitating a conversation about how to do better with what we have. So we're not duplicating collection efforts, and so people release the hold they might have on their data, and that we're able to look more on a pan-Canadian basis at what we have and what we do. It's a couple of ideas.
Shelly, I've got a couple of questions for you. One is, of all of the, some people might say that, I don't know what it is, the 15 cents on the dollar that the federal government contributes to health in this country, other than the dollars and cents, they haven't bought very much in terms of driving quality and value in healthcare. But the one area that it seems to me that they have a model that looks like it's working quite well is CPAC. And I'm wondering, in the context of a third mandate, how you think about the potential of directing more federal dollars for healthcare into this kind of model. And you talked about why it works, and I think one of the key reasons it works is that you're not seen as the federal government, and it's very much a pan-Canadian collaborative approach. Yet you see federal dollars driving consistency, quality, less variation, all of those good things for a very modest investment. So that's one question. How do we think about leveraging more federal dollars in this kind of direction? I think it's a good model. The other question I had was around the things you've talked about in the third mandate. We think about and struggle sometimes with this at the provincial level as well. Many of the issues that you've talked about aren't cancer issues. They're broader issues. The issues of prevention and public policy around health, the issues of palliative care, the issues of sustainability with drugs. They're not cancer issues. They're broader issues, but they're very much a cancer problem too. How do you think about your work in terms of if we're going to get to consistency and quality, for example, in palliative care, does a cancer-specific approach make sense, or do we have to tackle a broader issue around palliative care as an example?
Right. So I'm going to answer the last question first. So it is true that we don't represent the whole health system, obviously, but it is also true that sometimes when we try and boil the ocean, we don't do it very well. So we can hardly be accused in the health system in this country of moving quickly and radical change to transform the system. So my view is carve off a piece, do it well, and let the rest of the system be informed by what you've been able to accomplish. I feel that way about our clinical trials investment. You know, clinical trials in this country aren't set up, apparently, in a way that, well, they need some reform. So if we reform the cancer clinical trials, is there something the rest of the system can learn from that and build on? In palliative care, it is true that everybody in palliative care isn't dying of cancer, but boy, a whole lot of them are. And if we find a better way to deliver palliative care, we're going to have a spillover impact into the rest of the system. I do think, people ask me all the time, why cancer? And I say, well, it's the #1 killer in the country. And then they say, well, why don't we add all of the chronic diseases in? And I have to say, I mean, I'll do what we're asked to do, first of all. But I do have to say, I like the focus. I like the idea that that's what we're about. And it's not to belittle or undermine the other things, but we're about cancer. That's what we do. And so there's that sort of back and forth. And I know in CCO you have kind of that same kind of tension because you're doing many more things beyond cancer yourself right now. So that's that. And then I would say, you know, I've heard about autism, I've heard about Alzheimer's, I've heard about other initiatives that would like that same focus and the same federal leverage. And I say, that's great. Make sure that the community already supports it, because I really don't think we would have been successful at this if the first thing we had to do was convince everybody it was a good idea, right? That had already happened. In fact, those people had already convinced the federal government that they were standing together and it was a good idea. And if you have to start by doing that, I'm not sure how successful it would be. Now, the other question was,
CPAC's a good model for federal health dollars.
oh yeah, there you
More
go.
money in that kind of model.
Yeah. So, you know, I was at a conference last week and there was a lot of hand-wringing about we can't do anything because the federal government's not helping us in healthcare. And I was thinking, well, first of all, they are helping in some specific ways. They're not helping in the traditional ways. But also, I think there's some frustration about, like, why aren't we, the health system, just getting on with it? I mean, what parts do we own that we should be doing? And there's a lot of kind of resistance and waiting for the exact moment for things to be right. So I like this model. I appeared before David Naylor's innovation panel about CPAC, not talking about our work, but talking about our model. And saying, maybe this is an innovation, because people say all the time, oh, we can't get the provinces to work together. Well, we are getting the provinces, well, we aren't, but we are a part of an initiative where the provinces work together. So here's one that works. Why? How can you funnel the money, and how does it set up properly? I think it's worth doing. I think it's a good idea.
Were there more questions here? While we're just checking, just to follow on, Shelly, on this, Craig asked the question about what's other things in the new mandate, and you referred to post-market surveillance and kind of big data as potentially one area. What about this issue of taking on controversy? Again, not to be authoritative about it, but to cause a process to be brought together that would respond to questions or issues. You know, there are great examples. There's a whole set of blog sites out there where people do this all the time. They're bringing people together. The question that you raised about clarity on some of these, you know, what about HPV in boys? What about the use of what kind of thresholds for evaluating new drugs? You know, where is there a place for CPAC, again, not to stand up and say, well, we definitely should inoculate boys, we definitely shouldn't, but sort of lay out the story in a more comprehensive way. And, you know, don't try to tie it off with a bow, but put something out there that says, here's some guidance that we may be useful. Is there a place for that kind of work in the new mandate, now that we have our feet?
I think there is, and I'm hoping that it would be more trusted and credible than, because we're now an organization with 9 years. By the way, I work with like unbelievable people at the partnership. There's about 100 of us. We have biostatisticians, health economists, we have analysts, we have physicians, we have PhDs, it's just an awesome group who don't lead with their story, but every single one of them comes with a personal story about cancer, just like all of you. So that passion is fantastic and goes a long way. I just forgot your question. Taking on controversy. So there's two ways we can do that. One is produce the evidence and let others run with it, and I think we've spoken about that. But the other we've already played in, and we have, if you go on cancerview.ca, you'll see a section called The Truth of It video series. And these are video clips of Canadians, mostly just regular Canadians, not famous people, who have positions and thoughts about their cancer journey. And we've heard from people that they find those really powerful. We produce those and put them up. But they're people's personal opinions. So hands up if you saw Dr. Don Lowe's video when he was dying. Hands up if you knew CPAC produced it. I see all the CPAC staff. Yeah, we remember. So also on there, so that's a personal opinion. It got like pretty wide distribution. You know, and we don't have any work going on currently about physician-assisted suicide, but he has a strong opinion that Dr. Lowe had a strong opinion, as does his wife Maureen Taylor, that should be something. So it played a role. Now, that place in our portal is for personal opinion. We also had Dr. Larry Liebrecht, much valued member of our team who did a phenomenal piece for us when he was dying of cancer on palliative care. And on if we did palliative care better and well, how important it would be. So I like that, you know, the questions we ask ourselves in-house is if you could find one opinion, could you find the other? So that we're not advocating for a position. But the truth is, Canadians have both of those positions. That is the truth. It is called the truth. And we'll continue to use social media and other forms, I think, to highlight those opinions and get conversations going. I think that's a good place for us.
So thanks very much. Look forward to the future ones, and hope to see you at the next breakfast with the chief.